Good evening, everyone. A very warm welcome to all the esteemed doctors and participants joined for us for today for this IGCP Digital Live session. As we observe World COPD Day, it becomes essential to revisit the topic that remains both common and challenging in clinical practice: differential diagnosis of COPD. COPD is often misdiagnosed,
बंद
underdiagnosed, or
करके दोबारा शुरू
confused
करो.
with multiple overlapping respiratory conditions. Recognizing the subtle differences, whether it's asthma, ILD, cardiac limitations, or other airway diseases, can completely change a patient's management and long term outcomes. Today's session has been designed to bring clarity, practical insights, and updated clinical perspectives on the critical subject. It is my honor to introduce our speaker for the day, Professor Dr. Prashant Prakash. He is MD Medicine, MD in Pulmonary Medicine, MAMS, FICP, FIACM, Professor and HOD, SN Medical College, Agra. Dr. Prashant is an eminent pulmonologist and respected academician with extensive experience in diagnosing and managing complex airway diseases. His contribution to pulmonary medicine and critical care makes him the perfect expert to guide us through today's scientific discussion. With great pleasure, I would like to hand over the session to Dr. Professor Prashant Prakash to take us through this highly informative topic. Sir, this is to you. Thank you.
For giving this opportunity to deliver a talk on World COPD Day. And my topic is COPD differential diagnosis. What exactly should you suspect before you formulate and finalize a diagnosis of COPD? Basically, we have to understand the constellation of symptoms and evaluation leading to consideration of COPD as a diagnosis. We have to delineate modifiable and non modifiable risk factors for chronic obstructive pulmonary disease. We have to understand the diagnostic criteria for COPD, and we have to discuss the workup involved in any patient with dyspnea, chronic cough, and sputum production. So, differential diagnosis involves evaluation of the disease, risk factors, diagnostic criteria, and other considerations to consider. Evaluation of what is basically we have to assess the symptoms, what is the severity of breathlessness, what is cough, what is called the sputum production, wheezing, chest tightness, weight loss, or anorexia. Change in alertness or mental status, fatigue, confusion, anxiety or dizziness, pallor or cyanosis. COPD should be considered in any patient with a chronic cough, dyspnea, or sputum production. Evaluation. In the medical history, we must evaluate allergies, sinus problems, other respiratory diseases, risk factors, exposures, family history, comorbidities, medications, and prior hospitalizations. Other things which we must evaluate are vital signs, including the respiratory rate, pattern, effort, pulse oximetry. Must inspect for cyanosis. Must inspect the chest to assess AP diameter, whether it is a barrel shaped chest or not. Palpation and percussion of chest, lungs, auscultation for wheezing, crackles, and or decreased breath sounds. The question occurs that when should we consider COPD and with what type of symptoms? Basically, it is a chronic cough, any sputum production, dyspnea, and increased sputum production, or all of the above. The differential diagnosis is a huge list. Basically, pulmonary causes such as asthma, bronchogenic carcinoma, bronchiectasis, TB, cystic fibrosis, And this entire list. And non pulmonary considerations are also very important, that being congestive heart failure, hyperventilation syndrome, vocal cord dysfunction, obstructive sleep apnea, aspergillosis, chronic fatigue syndrome. What are the investigations which are important for consideration the diagnosis of COPD? Chest X-ray, arterial blood gas, spirometry, high resolution CT scan of the chest, and very important clinical examination. So this is the strength of recommendation for all these tests which are highlighted in this slide. Spirometry, coming to each one of them. Spirometry is actually the gold standard for diagnosis. It's the standard to establish severity and stage, and we must perform both a pre and post bronchodilator test because irreversible airflow limitation is the hallmark of COPD. Risk factors. We all know the main two risk factors, that is smoking and environmental pollution. Smoking is the major risk factor. Risk increases with the number of pack years smoked. Secondhand smoke in large amounts presents risk. And environmental pollution, which is now very important, smog and exhaust from vehicles, smoke from burning wood or other biomass fuels, and particulates in occupational dust. The various risk factors, the occupational irritants are again a host many. Agriculture worker, forage, important thing is endotoxin irritants. Coal miner, it is coal dust. Concrete worker, it is mineral dust. Construction worker, it is dust. Gold miner, it is silica. Hard rock miner, it is mineral dust. For rubber workers, it is industrial chemicals. All play a role in this contribution of the pathophysiology of COPD. Non modifiable risk factors include gender, that is the risk about which is equal in men and women and attributed to smoking habits of both genders. Age, generally COPD develops slowly. Most people are above the age of 40 years old when symptoms start. Alpha 1 antitrypsin deficiency, although mostly Northern European in heritage and a rare cause of 2% of COPD population, but at the same time, what is important is that this has not been studied in very great detail in India. So it is very premature to say that this is a mostly Northern European heritage and it is a rare cause. So, additional risk factors include severe lung infections as a child, previous tuberculosis, gastroesophageal reflux disease, which is may worsen COPD, lower socioeconomic status. The diagnostic criteria according to GOLD is consider COPD in any patient with the following: dyspnea, chronic cough or sputum production, and or exposure to risk factors. Gold criteria, the symptoms and risk factors are not diagnostic in themselves but should prompt spirometry in patients above 40 years of age. And diagnosis should be confirmed by pre and post bronchodilator spirometry. So basically, it is the combination of symptoms, risk factors, and spirometry. The diagnostic criteria are dyspnea, which is must be basically progressive, usually worse with exercise, persistent, described as increased effort to breathe. Chronic cough may be intermittent, may be non-productive. Chronic sputum production, any pattern may be associated with COPD. History of exposure to risk factors, tobacco smoke, occupational dust, chemicals, fumes, or smoke from cooking or heating fuels. Spirometry classification for COPD. First of all, what is most important is that the FEV1 upon FVC ratio should be less than 0.70. Once this is less than 0.70, then we go for an obstructive diagnosis and then we can categorize on the basis of FEV1. It is mild if the FEV1 is more than 80% of predicted value. It is moderate if it is between 50 to 79%. Severe if it is between 30% to 49%, and very severe if it is less than 30% of predicted value. Differential diagnosis, as previously enumerated, is the following, both in pulmonary and non pulmonary conditions. We will be basically discussing the differential diagnosis in some of the important ones. Now, the most important differential diagnosis, as we all know, is basically asthma. Asthma, what is asthma? It is episodic symptoms of airflow obstruction or airway hyperresponsiveness. Airflow obstruction, which is partially reversible by spirometry, characterized by reversibility and variability in symptoms and airflow, and alternative diagnosis should be excluded and by history and examination. What are the key indicators of asthma? There is cough, which is worse particularly at night, recurrent wheezing, chest tightness or difficulty in breathing, wheezing on physical examination, symptoms that occur or worsen in the presence of known triggers, and symptoms that occur or worsen at night. Spirometry helps in diagnosing the condition of asthma, and it should be performed when key indicators are present. And as we all know, there should be a reversibility defined as more than 12% increase in FEV1 from baseline. In fact, it is more than 12% increase in FEV1 or FVC and an absolute increase in FEV1 of about 200 ml. So that is the exact criteria of reversibility. Asthma, similarities with COPD, that it is major epidemiological causes of COPD and asthma seem to be the same. They both involve underlying airway inflammation. They can cause similar chronic respiratory symptoms and fixed airflow limitation. And they can coexist also with the other, making diagnosis more difficult. Asthma differences from COPD. Underlying immune mechanisms of chronic inflammation are different also in these two conditions. While asthma has an earlier age of onset in life, COPD, the onset is after 40 years. Symptoms in asthma vary while that in COPD are slowly progressive. Smoking is strongly associated with COPD. Asthma is associated with reversible airflow limitation. COPD is associated with irreversible airflow limitation. Asthma. Using spirometry to differentiate from COPD, post bronchodilator FEV1 less than 80% predicted together with a FEV1 upon FVC ratio less than 0.70 confirms airflow limitation that is not fully reversible. Asthma may show similar changes in chronic and more severe cases. PFTs may be needed to distinguish it from COPD. So, what is the clinical features in differentiating COPD from asthma? COPD, age is more than 35 years. Asthma, any age. Cough is persistent and productive in COPD. It is intermittent, usually non-productive in asthma. Smoking history is typically present in COPD. In asthma, it is variable. Dyspnea is progressive and persistent in COPD while it is variable in asthma. Nocturnal symptoms, breathlessness, and is there late in disease, the nocturnal symptoms, while nocturnal cough and wheezing are the hallmarks of asthma. Family history, atopy, diurnal symptoms, they are all less common in COPD and more common in asthma. Spirometry shows irreversible airway limitation in COPD. In asthma, it shows reversible airway limitation. Now, another important differential diagnosis is heart failure. When do we suspect heart failure? It's a midlife to late life onset associated with risk factors such as hypertension and CAD. The clinical presentation is fatigue, exertional and paroxysmal nocturnal dyspnea, and peripheral edema and crackles on auscultation. Pulmonary function tests, mainly what you will find is a decreased DLCO and possibly a restrictive abnormality when you have pulmonary edema. Chest radiography shows increased heart size, pulmonary vascular congestion, pleural effusions. Other recommended testing include echocardiography, BNP measurement, ECG, cardiac catheterization, etc. The third most important condition which mimics COPD is bronchiectasis. It is usually midlife in onset and progressive in exacerbations. Clinical presentation, there's a productive cough with large volumes of thick purulent sputum, dyspnea and wheezing associated with bacterial infections, crackles, and clubbing on examination. Pulmonary function tests show obstructive airflow limitation, both fixed and reversible. So, other things, chest radiography shows focal pneumonia, atelectasis, dilated bronchial tree, thickened airways. This is what chest radiography shows. And other recommended testing are bacterial, mycobacterial, and fungal sputum culture and chest CT. The fourth important differential diagnosis is tuberculosis. Onset is at any age associated with history of exposure. Local prevalence may suggest the diagnosis. Generally, in tuberculosis, you have productive cough, hemoptysis, fever, and weight loss. Pulmonary function tests are not particularly useful for diagnosis in tuberculosis. In chest radiography, you see infiltrates, nodular lesions, hilar retinopathy, cavitary lesions, or granuloma. Other recommended testing includes sputum for AFB culture, PPD, sputum cultures. They all confirm the diagnosis. Other rarer conditions mimicking COPD are bronchiolitis obliterans, which have onset at any age, but usually onset is younger, may be associated with history of flu-like illness, collagen vascular disease, or toxic fume exposure, non-smokers. Clinical presentation is often subacute with dyspnea, cough, and fever. The PFT shows a decreased vital capacity, decreased DLCO, usually no obstructive components is seen in bronchiolitis obliterans. Chest radiography is showing multifocal bilateral alveolar infiltrates. And other recommended testing is ESR, HRCT, shows hypodense areas, lung biopsy. Then other rare conditions are tracheobronchomalacia, which is onset usually more middle age, idiopathic or acquired during course of other illness. Clinical presentation shows cough, difficulty in clearing secretions, wheezing, recurrent bronchitis, pneumonia, and PFT show obstructive ventilatory impairment not responsive to conventional treatment with bronchodilators or inhaled steroids. Chest CT shows allows volumetric acquisition of data both at end inspiration and during dynamic expiration. There are other recommended testing for tracheobronchomalacia like flexible bronchoscopy, endobronchial ultrasonography, etc. Another relatively rare condition in Indians but very common in Caucasoid or European population is cystic fibrosis. So usually you have an early life onset, which is different from COPD, progressive with exacerbations associated with pancreatic disease, failure to thrive, intestinal obstruction, cirrhosis, steatoria. You have predictive cough with purulent sputum, dyspnea, and wheezing. Pulmonary function tests show a predominantly fixed airflow obstruction. Chest radiography shows bronchiectasis in upper lobes. You have other tests such as sweat chloride test, bacterium sputum culture, etc. So the key takeaway points are COPD is associated with several chronic respiratory symptoms that suggest as diagnosis. Symptoms overlap with a lot of conditions and particularly with asthma. History, risk factors, and progression of disease assist with diagnosis. Spirometry with and without bronchodilator usually necessary to make a diagnosis. So that is all which is there in this differential diagnosis of COPD, and these are the references. That is all in my presentation. If there is any, uh, if there are any questions, I would like to take them.
Thank you so much, sir, for this brief presentation. So, with all your permission, sir, can I take question one by one?
Sure, sure. Why not?
Okay. So, the first question is, what clinical clues help us differentiate COPD from asthma in patients who present with chronic cough and breathlessness?
Basically, the most important is first of all, in COPD, it is a progressive, persistent course, while in asthma, you would have diurnal variability and variability as such. The symptoms would not be the same on practically every day, right? Similarly, the symptoms will not be there at every particular point of time. In COPD, the point of the matter is that basically, apart from having a age at least above 35 or 40, right, and apart from the backdrop of a strong history of exposure to smoking or to pollution, basically the course will not have any variability. It should be progressive and it should be persistent.
Okay. Thank you so much for this brief answer, sir. I hope you did justice with the answer. So, the moving forward with the next question is, in a in a smoker with exceptional dyspnea, when should we suspect interstitial lung disease (ILD) rather than COPD?
Yeah, so basically, first of and foremost is that in a case of ILD, you will not particularly have exertional dyspnea. You will have dyspnea. And most often than not, this dyspnea is more important and more problematic than cough. And there would not be so much of a factor of exertional dyspnea. It would not be that the ठीक है, on an exertional basis, definitely things would be more manifest, but the patient would be dyspneic even at rest. That is the most important history difference between ILD and uh, between ILD and other conditions. Yes, that's all. As far as this question is concerned. Okay, okay.
बंदा
Response.
COPD from other obstructive airway diseases. I think there is an issue, so doctor in joining in sometimes. So, his practical approach and clinical clarity have truly added a great value for today's program. We are just waiting. Sir is coming in few minutes. So, we will take question from audience. Whatever we receive a question, we will take one by one. Yeah, doctor joined. So, you are unmute. Please unmute yourself. So you are mute.
Yeah.
Okay,
Is it
perfect, sir.
okay?
Yeah,
Yeah.
perfect, sir. So we are taking question. So the question is, how useful are spirometry patterns and bronchodilator response in COPD from other obstructive airway diseases?
So basically, spirometry and is very important and very diagnostic in the diagnosis of COPD. But for the very simple reason that there would be irreversible airflow limitation, that is after administering of the bronchodilator, the FVC or FEV1 would change by less than 12% and less than 200 ml in absolute value. But there are two or three things important which you have to take into consideration. That does not mean that bronchodilators will not be beneficial or helpful in COPD. They will still be beneficial or helpful in COPD, but that is the basic criteria upon which we demonstrate reversible and irreversible airflow limitation. Ideally, COPD should have a irreversible airflow limitation. But as I said in my presentation, it is not only spirometry, but a constellation of tests which are important, which include X-ray, which also includes arterial blood gas analysis, and which most important involves history and clinical examination while making a diagnosis of COPD patient. So while spirometry is very important, but it is not the whole and soul thing.
Okay. Thank you so much for this brief answer, sir. So the moving
Yeah.
forward with the last question is, when respiratory symptoms overlap, what red flag features indicate that diagnosis may be cardiac rather than pulmonary?
Yeah, so that's a very important question, and hence you have that old term which you can say is bronchial asthma and cardiac asthma. So, what is most important is that when you are dealing with cardiac asthma or heart failure, which is the more precise term. So, basically, in heart failure, number one, you will have exertional dyspnea. So, there'll be exertional dyspnea, there will be the cough and chest pain will be exertional. There will be other symptoms and signs which will give you the clue, such as there will be presence of edema, there will be presence of basal crepitations. On chest X-ray, you may find the features of pulmonary edema, that is a typical bat swing appearance, curly A, curly B lines. Then on chest X-ray, you would have the typical probably enlargement of heart. Then you would find features on ECG which are suggestive of some kind of ischemia or infarct. Then on echocardiography would give you additional features. So differentiating between cardiac asthma and bronchial asthma is very important. It's not dependent on only one particular thing. It is dependent on a host of other things when you have to take into consideration.
Oh, thank you so much, sir, for your detailed and insightful
Thank you
session
very
on
much. Thank you very
differentiating
much.
COPD,
Yeah, I'm
on
sorry
differentiating.
there have
Yeah,
been a
yeah.
lot of disturbances during this presentation, and I would like to apologize for the same. And I hope I have managed to deliver the message.
Yeah, sir. And thank you, sir, for this insightful session on differentiating COPD from other respiratory conditions. Your practical approach and clinical clarity have truly added a great value for today's program, sir. Sir, so on behalf of IJCP, sir, we extend a sincere thanks to all the doctors and participants who joined us, wishing you all a wonderful and healthy evening. Thank you and take care. Thank you.
Thank you. Thank you. Stop.